Okay, let's dive in. Today we're tackling, well, a really fundamental topic: human sexuality.
Absolutely. And it's something that, despite being so central to life, is just surrounded by silence, or worse, misinformation.
It really is. You'd think we'd have it figured out, but our sources paint a pretty stark picture, especially regarding formal education.
Yeah, as of 2022, think about this. Only 29 U.S. states even required any kind of sex ed.
Wow, only 29.
Right. And get this, more than half of those didn't mandate that it had to be medically accurate information.
That's staggering. And contraception.
Even fewer required education on contraception. And when it comes to LGBTQ plus relationships,
Often just ignored. Or worse.
exactly, omitted or sometimes actively discriminated against. Anything outside the heterosexual norm often gets sidelined.
Which leaves this massive knowledge gap for so many people.
It does, and it begs the question, if schools aren't providing solid info, where are folks getting it?
Probably those unreliable places, like you said.
Of
Friends, maybe the internet, media, which can lead to real misconceptions. And shame.
a lot of unnecessary shame, yeah.
So that's our mission with this deep dive. We want to give you a kind of shortcut.
Mm.
We've sifted through some really excellent sources to pull out the crucial insights, clear up confusion, and maybe reveal some surprising truths.
To help you navigate this whole complex area with, hopefully, more confidence and clarity.
Okay, first things first. Let's define sex and sexuality, because it's actually more complex than you might think.
Right, we often think sex is just biology, the physical act, but it's biological and cultural and even deeply personal.
And the cultural part is huge. Our sources highlighted this fascinating survey from 2017.
Oh yeah, the one asking straight identifying folks in the U.S. what counts as sex?
Right, that's the one. So like 90% agreed penis and anus counts.
Okay, fairly high agreement there.
But then opinions were all over the place for other acts, things involving hands or mouths.
It really shows how much our cultural background shapes what we even label as sex, even within the same country.
Totally. So your definition might be different from someone else's, and that's okay. And sexuality itself is way bigger than just the physical act, isn't it?
Oh, absolutely. Much broader. The Kinsey scale started getting at this spectrum idea. And Dan Savage's three-layer cake analogy is pretty useful, too.
How does that work again? The 3 layers?
So layer 1 is sexual orientation, basically, who you want to be intimate with, your attractions.
Okay.
Layer 2 is sexual behavior, who you actually are intimate with, which might not always match orientation.
Right. Circumstances, opportunity.
Exactly. And layer 3 is sexual identity, who you tell people you are, or how you identify publicly.
Ah. And when those layers don't quite line up, say your internal feelings clash with your external identity because of societal pressure.
That can cause real distress. Stress, depression, feeling like you're not being authentic. It's like Savage called it a funfetti cake when things get messy.
That makes sense. And this connects to the whole idea of virginity, doesn't it? Our sources really push back on the traditional view.
They really do. Especially that historical focus on penis and vagina sex as the definition. It puts this one specific act way up on a pedestal.
Implying it's the ultimate experience, or the only one that counts.
And historically, where does that come from? A lot of it is tied to, well, property and patriarchy, ensuring paternity, control.
Like old MacDonald had a farm and control over his wife's sex life, kind of thing.
Kinda, yeah.
Yeah.
And then there's the hymen myth,
Right, the idea that the hymen is proof of virginity.
which is just not true. Hymens vary so much. They can stretch or thin from exercise, tampons, all sorts of non-sexual things.
And medical experts are clear. There's no physical test to definitively say if someone's had P and V sex.
None. But that social script, it causes real harm, shame, bullying.
And it can make people hesitant to get medical care, right? Especially, say, LGBTQ plus folks whose experiences don't fit that narrow definition.
Absolutely. It's really powerful, actually, reading in the sources how many LGBTQ plus individuals talk about losing virginity more as a process of self-discovery or identity clarification.
Or that coming out felt way more significant than any specific first time.
Exactly. It just underscores that virginity is a social idea, a construct, not some biological switch that gets flipped.
Okay, let's get into some anatomy, demystify things a bit. Starting with female anatomy. Big common confusion here.
Vulva versus vagina.
Yes. People use vagina for everything down there, but that's not right, is it?
Nope. Everything you can see on the outside, that's the vulva, the labia, the clitoris opening, all vulva.
And the vagina?
That's the internal canal. It's actually surprisingly short when not aroused, average just over 2 inches, though it can stretch significantly.
And the word itself, vagina, the Latin origin is kind of telling.
Yeah, sheath or scabbard, but also related to words meaning to be ashamed. That historical shame definitely colored how it's been studied and discussed.
Or not studied in some cases, like the clitoris.
Oh, absolutely. It is
Yeah.
pretty mind-blowing. The clitoris, which is key for pleasure for so many people.
It wasn't fully mapped anatomically until 2005 by a woman, Helen O'Connell.
Right. Compare that to the penis described in detail way back around 35 BCE.
That just screams historical bias in medical attention, doesn't it?
It really does. And the clitoris is amazing. Over 10,000 nerve endings, mostly dedicated to pleasure.
We should also talk about appearance diversity.
Yes, vulvas look all different ways. Inner lips might be longer than outer, one side different from the other, different hair patterns, darker skin.
That darker skin is normal, right? Melanin and hormones.
Totally normal. It's all part of the healthy range. Just like faces, vulvas are unique.
Okay, what about wetness and discharge? People worry about that.
Good point. There's arousal fluid, the natural lubrication when you're turned on. And then there's daily discharge.
Which is
Basically, the vagina's self-cleaning mechanism, its wash cycle, shedding old cells, mucus, keeping things healthy.
and it's normal to have some every day.
Yep. About half a teaspoon to a full teaspoon is typical. It can vary with your cycle, of course.
This connects to the vaginal microbiome, right? This whole ecosystem inside.
Exactly. A magnificent world, as one source put it. Mostly lactobacillus bacteria.
Like in yogurt.
Similar idea. They produce lactic acid, which makes the vaginal environment acidic, kind of like wine vinegar or pickles.
And that acidity is protective.
Yes, it keeps potentially harmful bacteria and yeast in check. And that lactic acid, that's often why the crotch of your underwear might get bleached over time.
Uh-huh. Mystery solved for some folks. So the key takeaway is,
Vaginas are self-cleaning. You really don't need soap inside. Douching or using harsh soaps can actually disrupt that delicate pH balance and cause problems.
so unless discharge changes color dramatically, like green or gray, or gets really foamy or smells fishy, or is bloody when it's not your period, it's probably fine.
Generally, yes. Okay, let's switch gears to male anatomy. The penis.
Also carrying a lot of historical baggage, symbol-wise.
Definitely. Fertility symbol in ancient Greece, Egypt, Rome.
Yeah.
But then early Christianity shifted things, sometimes viewing it as a symbol of sin or temptation.
Interesting how perceptions change. And biologically, we didn't always understand erections.
No. It was actually Leonardo da Vinci, back in the late 1400s, who first figured out erections were about blood flow, not trapped air, which was a common belief.
Simple mechanics, really. One exit for urine and semen, the meatus. Semen takes a bit of a scenic route to get there.
It does. Now, common questions. What about breaking a penis?
Right. Is that possible? There's no bone.
Correct, no tone. But the spongy tissues inside, the corpora cavernosa, can rupture if the erect penis is bent forcefully. It's called penile fracture.
Ouch. Sounds like it needs medical attention.
Immediately, yes. And blue balls,
Ah, the dreaded term.
medically known as epididymal hypertension. It's just a temporary buildup of blood in the testicles from being aroused for a while without ejaculating.
Is it dangerous?
Nope, not dangerous, maybe uncomfortable, and it happens with the clitoris too, by the way. Relief comes eventually, either through orgasm or just letting the arousal subside.
Okay, let's talk size. This is a huge source of anxiety for many people with penises.
Huge. And our sources point out this is heavily emphasized in Western cultures, linking size to masculinity, power, sexual prowess.
Which often doesn't match reality. What does the research say about average size?
A large 2023 study put the average flaccid length around 3.4 inches, erect length about 5.5 inches. Girth averaged 3.7 inches flaccid, 4.6 inches erect.
But averages are just averages, right? There's a wide range of normal.
Exactly. And here's the kicker. One study found 85% of women were satisfied with their partner's penis size.
85% compared to...
Only 55% of men being satisfied with their own size.
Wow. That says so much about cultural pressure versus actual experience.
It really does. It's often insecurity driven by cultural messages, not biological reality or partner feedback.
All right, let's move into identity, orientation, and transition, starting with a really fundamental distinction. Sex versus gender.
Crucial distinction, often confused. Sex, biologically, is usually about physical traits, genitals, chromosomes, hormones, often assigned at birth as male or female.
But even that biological picture isn't always strictly binary, right?
Not at all, as we'll see with intersex variations. Gender, though, is different. It's more about the social and cultural ideas, roles, expectations associated with being male or female.
And gender identity.
That's your internal personal sense of who you are, whether you identify as a man, a woman, maybe a blend of both, or neither.
And this idea of only two genders, the binary, that wasn't always the global norm, was it?
Not by a long shot. Our sources emphasize that the strict gender binary was largely spread through European colonialism.
How so?
Colonial powers actively suppressed or misunderstood indigenous cultures that had long traditions of recognizing third, fourth, or blended genders.
Like two-spirit people in many Native American cultures.
Exactly. Or the Mahu in Hawaii, Fa'afafine and Fa'atama in Samoa. These cultures had much more fluid and inclusive understandings of gender that were often erased or forced underground.
Which leads us to intersex experiences.
Right. Intersex people are born with physical sex characteristics, chromosomes, gonads, hormones, or genitals that don't fit neatly into typical male or female boxes.
So maybe someone has XX chromosomes but develops tests, or XY chromosomes, but their body doesn't respond to certain hormones in the typical way.
Precisely. And it's not vanishingly rare.
Mhm.
Estimates suggest about 17 in every 1,000 people are intersex in some way. That's millions worldwide.
And historically, there's been a practice of surgeries on infants.
Yes, often medically unnecessary surgeries performed on intersex babies to make their bodies conform more closely to binary norms. This is increasingly seen as problematic and harmful by intersex advocates and medical ethicists.
Okay, so then what about transgender folks?
Transgender, or trans, is an umbrella term for people whose gender identity differs from the gender they were assigned at birth based on their sex characteristics.
And non-binary.
Non-binary people identify outside of the man-woman binary altogether. Their gender identity might be a mix or fluid or something else entirely.
And transitioning, what does that involve?
It's a process, and it looks different for everyone. It can involve social transition, changing names, pronouns, clothing style, hair.
And sometimes physical changes.
For some, yes. That might include gender-affirming hormone therapy, like taking testosterone or estrogen or surgeries, to align their body more closely with their gender identity.
What about for kids? There's a lot of talk about that.
Yeah, for young children, transition is primarily social. Before puberty, medical interventions aren't typical, though puberty blockers might be discussed as an option later.
What do puberty blockers do?
They pause puberty temporarily, giving the young person more time to explore their identity before permanent physical changes occur. They're reversible. Hormone therapy, like estrogen or testosterone, generally isn't considered until later adolescence, often around 16 or 18 plus I, depending on guidelines and individual circumstances.
And the idea that gender-affirming surgeries are new or experimental.
Not true. These kinds of surgeries have been performed safely for decades, and studies consistently show that regret rates are extremely low.
What's the impact of this care?
Overwhelmingly positive, according to research. Access to gender-affirming care significantly improves mental health, reduces depression and anxiety, and enhances overall well-being for trans and gender-diverse people.
Okay, shifting slightly now to sexual orientation.
Right. Who you're attracted to. And again, it's not just two boxes. It's a spectrum.
We have straight, gay, lesbian, bisexual.
Asexual people who experience little or no sexual attraction. That's also a spectrum, the A spectrum, including folks who are demisexual, meaning they only feel attraction after a strong emotional bond forms.
And the plus in LGBTQ plus covers many other identities too.
Exactly. Pansexual, queer, acknowledging the wide diversity of attraction.
And just like with gender, history shows more diversity than we might assume now.
Oh, definitely. Many ancient cultures were much more accepting of same-sex relationships or broader expressions of sexuality than, say, post-Christian Europe became.
Colonization and religious dogma really narrowed the acceptable range, didn't they? Stigmatizing and even criminalizing homosexuality.
Massively. And that medical pathologizing took a long fight to undo. Remember the Dr. Anonymous story?
Vaguely. Refresh my memory.
Dr. John Fryer, a psychiatrist who in 1972 had to speak at the American Psychiatric Association conference wearing a mask and using a voice distorter.
Why?
Because he was gay, and homosexuality was still listed as a mental illness in the DSM, the big diagnostic manual.
Right.
He spoke about the discrimination faced by gay psychiatrists. It was a huge, courageous moment.
Wow. And that helped lead to homosexuality finally being removed from the DSM.
It was a key catalyst, yes. It took years of activism, but it showed how deeply ingrained the stigma was, even within medicine. It wasn't just a medical reclassification, it was a human rights battle.
And one last important point here. Sexual fluidity.
Yes. The idea that your attractions aren't necessarily fixed for life. They can change, evolve, shift over time.
So who you find attractive at 20 might be different at 40 or 60?
Exactly. Our experiences, our understanding of ourselves, our relationships, they can all influence who we're drawn to. It's another layer of that dynamic human experience. Okay, let's dive into the practicalities of sexual health and reproductive choices, starting with STIs, sexually transmitted infections.
And the stats here are pretty sobering.
They really are. One source mentioned over 67 million people in the U.S. had an STI back in 2018, and around 20 million new infections happen each year.
Wow. And a huge chunk of those are among young people, right?
Almost half, actually, occur in the 15 to 24 age group, so very common.
What are the main types we should know about?
Broadly, you can think of two categories: bacterial STIs like chlamydia, gonorrhea, syphilis.
Yeah.
The potentially good news here is these are generally curable with antibiotics.
Okay. And the other category?
Viral STIs. Think herpes, HPV, human papillomavirus, hepatitis B, and HIV. These aren't currently curable, but they are treatable. Medications can manage symptoms, reduce outbreaks, and lower the risk of transmission significantly.
So a crucial point from our sources is testing, right? Because you might not even know you have one.
Exactly. Most STIs don't have obvious symptoms, especially early on. They're asymptomatic.
Meaning regular testing is key if you're sexually active, particularly with new or multiple partners.
Absolutely vital. And prevention, of course. Barrier methods are huge.
Condoms, external and internal ones, and dental dams for oral sex.
Right. They're highly effective at preventing the exchange of bodily fluids that transmit many STIs. Also, cleaning sex toys between partners or uses.
And communication. Being able to talk openly with partners about testing, status.
Show me your results, I'll show you mine kind of approach. Takes away the guesswork and stigma.
What about HIV prevention specifically? PPP and P.
Yes. PP is pre-exposure prophylaxis, a daily pill someone takes to drastically reduce their risk of getting HIV before exposure. PP is post-exposure prophylaxis medication taken after a potential exposure to prevent infection.
And it's important to note these aren't just for gay men, right?
Absolutely not. Anyone at risk of HIV exposure can potentially benefit from pre-AP or PUP. It's about risk behaviors, not identity groups. But sadly, stigma around HIV and other STIs still persists.
Okay, shifting to contraception, preventing pregnancy.
The basic goal: stop sperm from meeting egg. Lots of ways to approach that.
What are the main categories?
You've got natural methods, like withdrawal, the pull-out-and-pray method.
Which isn't super reliable.
Not at all. About a 1 in 5 failure rate with typical use. Then there's fertility awareness or the rhythm method, tracking your cycle to avoid sex during fertile times. Also tricky, maybe 1 in 4 failure rate if not done perfectly.
Some more reliable options.
Barrier methods again. Condoms external, around 98% effective with perfect use, and internal, around 95%. Plus they prevent STIs.
Double duty, then hormonal methods.
Right. Pills, patches, rings, shots, implants, hormonal IEDs. These generally work by stopping ovulation or thickening cervical mucus to block sperm.
They're very effective.
Highly effective when used correctly. But they can have side effects, especially initially mood changes, nausea, spotting. These often lessen after a few months as the body adjusts.
Now, there's some really crucial and pretty disturbing historical context around birth control development in the U.S.
Yes. It's deeply tangled with the eugenics movement, particularly in the early 20th century.
Forced sterilizations.
Exactly. Targeting poor women, women of color, Black, Latina, Native American women. Procedures like the Mississippi appendectomy, which was actually a forced hysterectomy or tubal ligation disguised as appendix removal. Horrifying.
And the early pill trials.
Also deeply unethical.
Yeah.
Tested on women in Puerto Rico, often poor women,
Yeah.
without proper informed consent about the risks or even that they were in a trial. Some women experience severe side effects, even death.
It's vital to remember that history when we talk about reproductive health care today.
Absolutely. It shapes trust, access, and highlights the need for ethical practices in reproductive justice.
What about male birth control? Feels like the burden falls mostly on people who can get pregnant.
It largely does. There's ongoing research into male options, a pill, a gel, but progress has been slow.
Why is that?
Well, one factor mentioned in the sources is the threshold for acceptable side effects. Hormone shots for men were trialed, but side effects like acne, mood swings, weight gain were deemed unacceptable.
Even though those are similar side effects many women experience with hormonal birth control.
Precisely. It highlights a kind of double standard in drug development historically, but research continues.
Quick mention of emergency and permanent options.
Sure. Emergency contraception, the morning after pill, works best within 72 hours, but can be effective up to 5 days after unprotected sex. And permanent methods include vasectomy for men and tubal ligation, getting tubes tied for women.
Though sometimes doctors are hesitant to do tubal ligations for younger women without children, right?
That can be a barrier, yes. Concerns about future regret, sometimes based on societal assumptions rather than individual choice.
Okay, let's touch on pregnancy and childbirth. A huge experience.
Truly profound. Starts with fertilization, then implantation in the uterus. There's a small, about 2% risk of ectopic pregnancy where it implants outside the uterus, usually in the fallopian tube, which is a medical emergency.
Like a miscarriage.
Sadly common. About 10–20% of known pregnancies end in miscarriage, often very early on. And it's often surrounded by unnecessary silence and shame.
Pregnancy itself involves massive changes over 3 trimesters.
Huge physiological shifts. Morning sickness, which might actually be an evolutionary adaptation to protect the fetus from potentially harmful foods. Breast changes, preparing for lactation. Feet can grow. Blood volume nearly doubles. Organs get rearranged to make space.
It's a marathon for the body and childbirth.
Typically 3 stages. First stage, cervix dilates. Second stage, pushing and delivery of the baby. Third stage, delivery of the placenta.
Vaginal tearing or episiotomies, surgical cuts are pretty common, especially for first births.
Yes. And C-sections, surgical births, account for about 3 out of 10 births in the U.S.
Then there's the 4th trimester.
Right. The first 3 months postpartum. A critical period for physical and emotional recovery for the birthing person. The body needs time to heal and adjust.
And a really important point, trans men and non-binary people get pregnant and give birth too.
Absolutely. They need access to inclusive, affirming reproductive and perinatal health care, just like anyone else.
Finally, in this session, abortion.
Yes. The sources describe 2 main types. Medical abortion, using pills, mifepristone and misoprostol, usually done early in pregnancy, and procedural abortion, often using gentle suction aspiration, done in a clinic.
How safe are these procedures?
When performed by trained providers, abortion is very safe. One major study found a complication rate of around 2%, much safer than carrying a pregnancy to term, statistically.
What are common reasons people seek abortions?
They vary widely. Financial instability, timing not being right, needing to focus on existing children, health concerns, not wanting to be pregnant.
Yeah.
It's a deeply personal decision.
And the Turnaway study provided some powerful insights on regret, didn't it?
It did. A landmark study following women over 5 years. It found that 97% of women who received an abortion reported it was the right decision for them 5 years later.
Even if the decision itself was difficult at the time.
Exactly. It strongly counters the narrative that abortion commonly leads to long-term regret or negative mental health outcomes. For most, relief and certainty it was the right choice are the dominant feelings long-term.
Okay, let's shift focus now to pleasure, the pleasure principle, which is about way more than just, the mechanics.
Absolutely. And central to pleasure is consent.
Which needs to be more than just the absence of a no, right?
Definitely. We need to move past no means no to embracing yes means yes.
Yeah.
An enthusiastic yes.
Why is the absence of no not enough?
Because sometimes people can't say no. Our sources mentioned the freeze response. It's an involuntary reaction to threat or fear, where someone literally can't move or speak.
So they might be terrified inside, but physically unable to resist or say no.
Exactly. Which is why relying on someone not saying no is dangerous and unreliable. We need active, willing participation.
And a physical response, like an erection or lubrication or even orgasm, doesn't automatically mean consent is present, does it?
Absolutely not. Those can be involuntary physiological responses, even in situations of fear or non-consent.
Mm-hmm.
Consent is about a person's conscious, willing agreement.
And it has to be freely given. No pressure, no manipulation, no coercion.
Right. Power dynamics matter here, too. Can someone truly freely consent if there's a big power imbalance in the relationship or situation?
What about alcohol or drugs?
That complicates things significantly. Someone who is incapacitated cannot consent. It's crucial to check in, ensure your partner is coherent and enthusiastically willing. When in doubt, stop.
And a yes isn't a contract for the whole encounter, is it?
Not at all. Consent is ongoing. A yes to one thing isn't a yes to everything, and a yes can be withdrawn at any time. If someone says stop or indicates they're no longer comfortable, things must stop immediately.
So the big picture here, consent isn't some annoying hurdle to jump over.
No, it's the foundation. It's actually the gateway to better sex. Studies show enthusiastic consent is linked to higher sexual satisfaction for everyone involved.
Makes sense. Okay, let's talk orgasm. The big O.
Right, defined as that sudden, intense, involuntary release of built-up sexual tension.
How does it happen, typically?
Well, for most folks with penises, it's primarily through direct penis stimulation. For most folks with vulvas, it's primarily through clitoral stimulation, either external on the glands or internal, stimulating the internal parts of the clitoris through the vaginal walls.
So pleasure can come from lots of places.
Oh, yeah. Erogenous zones are all over nipples, neck, ears, anus. Even just thoughts or fantasy can lead to arousal and sometimes orgasm.
What about the G-spot? Is that a real thing?
The consensus seems to be that the G-spot isn't a distinct anatomical structure, but rather an area on the front wall of the vagina where stimulating the underlying internal part of the clitoris feels good for some people.
So still related to the clitoris, really.
Most likely, yes. Now, understanding the response cycle. Masters and Johnson did groundbreaking work back in the day.
Excitement, plateau, orgasm, resolution.
Right. Revolutionary for its time. Observing things scientifically. But it had limitations. Didn't really account for desire beforehand or the huge individual differences.
So newer models are more nuanced?
Yes, like the dual control model developed at the Kinsey Institute. It suggests everyone has sexual excitatory systems, the ons or accelerator, and inhibitory systems, the offs or brakes.
And these are both physical and psychological.
Exactly. Things that turn you on, things that turn you off. Stress, anxiety, feeling unsafe, those are big offs. Feeling desired, safe, trusting your partner, big ons. Orgasm depends on the balance between these.
This helps explain the orgasm gap, doesn't it?
It really does. That significant difference where in heterosexual encounters, something like 95% of men report usually or always orgasmic.
Compared to only about 65% of women.
Right. Why the gap? Part anatomy, the penis is easily stimulated during intercourse. The clitoris often isn't, or not effectively.
And part social cultural.
Big time. Sexual scripts, the unspoken rules or expectations about how sex should go, often prioritize male pleasure and orgasm.
Media, especially porn, often reinforces this, right? Showing women easily orgasming from penetration alone.
Exactly, which isn't the reality for most. So the solution involves understanding female anatomy, hello, clitoris, and consciously ditching those limiting scripts. Focus on what actually feels good for both partners.
And maybe remembering that orgasm isn't the only goal.
Crucial point. Orgasm is great, but it doesn't have to be the crown jewel or the only measure of a good sexual experience. Exploring pleasure, intimacy, connection for their own sake is just as valid.
Okay, what about solo pleasure? Masturbation.
Our sources are clear, totally normal, incredibly common, across genders, orientations, ages, whether you're single or partnered.
It's not just something people do if they don't have a partner.
Not at all. It's a healthy part of human sexuality for many people throughout their lives.
And there are benefits, right? Beyond just feeling good.
Definitely. Relaxation, stress relief can help with anxiety or even pain, promotes better sleep for some. It increases blood flow, keeping genital tissues healthy.
And maybe even a link to prostate health.
Some research suggests a potential link between more frequent ejaculation and a lowered risk of prostate cancer later in life, though more research is needed.
Now, the history here is wild. Masturbation hasn't always been seen as normal or healthy.
Oh, far from it. It's fascinating. Some ancient creation myths actually involved gods masturbating to create the universe.
Seriously? Like who?
The ancient Egyptians had a story about the god Adam creating the cosmos that way, so it wasn't always taboo.
But then things changed. Religions condemned it, and doctors.
Yeah, starting around the 1700s, some influential doctors spread really harmful, completely inaccurate ideas, like semen being a precious vital fluid that shouldn't be wasted.
Leading to beliefs that masturbation caused. Weakness? Insanity.
All of the above. Blindness, infertility, epilepsy, just a whole list of baseless fears. This led to some truly bizarre and disturbing things.
Like those Victorian anti-masturbation devices, spiked rings in cages.
Horrifying, yes. And even Kellogg's cornflakes. John Harvey Kellogg invented them partly as a bland, plain food he thought would discourage sexual urges and masturbation.
Wow, breakfast cereal as a moral crusade.
Pretty much. So despite that strange and damaging history, we now know masturbation is normal and healthy.
Okay, last stop on the pleasure tour. Kinks.
Right. Kinks are basically non-conventional sexual interests, desires, fantasies, or practices. Things outside the vanilla norm.
And people often assume kinks are rare or weird, but the sources suggest otherwise.
Much more common than you'd think. One Canadian survey found over half of people fantasized about things like being watched during sex, or BDSM themes like dominance or
Well,
submission.
over half. And another study.
Found huge percentages, like 68% of Italians, over
Yep.
90% of Americans had fantasized about dominating someone or being dominated. Fantasies are incredibly common.
Where do kinks come from? Any ideas?
Hypotheses vary. Some might be learned associations, maybe something got accidentally paired with arousal early on. The origins aren't always clear.
Let's talk briefly about BDSM. Bondage, discipline dominance, submission, sadism, masochism.
Right. It often involves playing with power dynamics, control, and sometimes consensual pain or sensation play.
Pain and pleasure seem linked in the brain somehow.
They are processed in overlapping areas, yes. For some people, certain types of sensation, even if mildly painful, can be intensely arousing in the right context.
But the crucial thing about BDSM communities.
Is the intense focus on consent. It's paramount. Clear communication, negotiation before any play happens, setting limits, desires, using safe words to immediately stop or modify the action if needed, and aftercare, checking in emotionally and physically afterwards.
So safety and consent are built into the culture.
Ideally, yes. And it's not always about sex itself. Sometimes it's more about the psychological thrill of the power exchange, giving up control or taking it in a safe, agreed-upon way.
It really shows the incredible range of what people find pleasurable and connecting. Wow, okay. We have covered an incredible amount of ground today.
We really have. From the nitty-gritty of anatomy to the complexities of consent and identity.
And I think the big theme emerging from all these sources is just how, well, deliciously diverse human sexuality is.
Absolutely. It's dynamic, it changes, it's shaped so much by our culture, our history, our personal experiences.
What one person calls sex, another might not. What one era condemned, another accepted.
It shows there's really no single fixed blueprint for how to be sexual.
No. So what does all this mean for you listening right now? Here's maybe a final thought to chew on.
Mhm.
Our culture often gives us these rough drafts for how to live our lives, especially around sex and relationships. They're not set in stone blueprints.
Yeah, more like suggestions, often based on outdated or limited ideas.
So the question is, how might understanding all this, the history, the diversity, the biology, the psychology, how might that empower you to maybe edit that draft?
To scribble in the margins, cross things out that don't fit.
Exactly. To write your own plot when it comes to pleasure, identity, and connection.
That's a great way to put it. And the way to do that editing, keep learning
Stay curious. Keep asking questions about yourself and the world.
and talk about it. Open communication with partners, with trusted friends, maybe even with healthcare providers is so key.
That curiosity, that communication, that's really the path to understanding yourself better and having healthier, maybe more joyful experiences. Keep exploring.